another important topic today, thyroid. ठीक है, बहुत question, too many questions you have, important ones I would be discussing in which you must know. So first is Hashimoto's thyroiditis and another condition would be Graves' disease. दोनों में common क्या है? Both of them are autoimmune. Autoimmune है इसलिए they are more common in females. ठीक है, one condition is causing hypothyroidism, and which is that is Hashimoto, because thyroiditis हो रहा है, there is destruction of the thyroid gland, thyroid hormone is not being released, so you are going to have increased TSH but the thyroid T3 T4 levels are going to be reduced, versus Graves' disease जिसमें there is stimulation, there is more of TSH which is going to lead to a decreased level of T3 and T4. So that is a condition of hyperthyroidism, and there is hypothyroidism in Hashimoto thyroiditis. So I'm going to start with Hashimoto thyroiditis first. You get a short note on it. It is an autoimmune condition that we all know. Destruction of the thyroid gland is there, and it is the most common cause of hypothyroidism in areas which are iodine sufficient, in the endemic in the areas where the iodine level is normal. More common in female, and the age group is going to be 45 to 65 years. So you have to remember that it is more common in females. What is actually happening, that there is breakdown of the cell tolerance. As you all know, ठीक है, autoimmune है, so you have to remember that in any autoimmune condition there is going to be genetics involved, as in here in both Graves and in Hashimoto's यही वाले polymorphisms are being involved. Polymorphism in genes like CTLA4, PTP and 22 which are involved in immune regulation. ठीक है, so what is happening? You have normal thyroid epithelium. ठीक है, there are formation of autoantibodies which are going to destruct your own thyroid gland, your own thyroid follicular cells. So with this immune response, this destruction can be CD8 mediated or CD4 mediated, or it could be antibody mediated also, as we all know. ठीक है, सब everything was clear in immune chapter. So you can have T cell mediated cytotoxicity, or you can have CD4 helper T cell mediated when interferon gamma is released. So macrophage mediated thyrocyte injury, or you can have antibody mediated cytotoxicity. But हो क्या रहा है? All the benign conditions of thyroid gland में they will have diffuse enlargement of the thyroid gland. What does that mean? Diffuse का मतलब क्या होगा? Both the glands are going to be involved. Versus neoplasm, which are neoplastic. So इसमें focal enlargement of the thyroid gland, only one lobe or some part of the thyroid gland is going to get enlarged. So diffuse enlargement है. Look at this. I'm going to describe the gross and the images in here also. Detailed notes are being attached in the PDF, which is there in the description box. So you have the normal thyroid gland. The color or the cut surface of the normal thyroid gland is mahogany brown. Mahogany brown color तुमको बोलना है when you are describing the gross specimen of the thyroid gland. Another important feature about the thyroid gland is the capsule. Thyroid is an encapsulated organ. So when you identify the normal tissue, you have to say that the cut surface is mahogany brown in color, and it is an encapsulated organ which is either diffusely enlarged, or it can have multinodules, or it is focally enlarged as in neoplasm. ठीक है, now what happens in Hashimoto thyroiditis? Thyroiditis है तो इसका मतलब inflammation है, destruction है, और inflammation और destruction में कौन से type of cells are involved? They are B cells which are there, and there are plasma cells. So lymphocytic infiltrate की वजह से this cut surface is going to have a pale yellow appearance, as you can see in the image. So the gland is diffusely enlarged, the capsule is intact because it is a benign condition. Rupture हो जाएगा तो इसका मतलब malignant है, and it is having a firm है ना, firm सा है, देखने में लग रहा है, pale nodular yellow tan cut surface. वब इस कट सरफेस की हमने स्लाइड बनाई तो माइक्रोस्कोपी में व्हाट यू आर सीइंग, यू आर हैविंग दीज एज द नॉर्मल फॉलिकल्स, एंड इन बिटवीन द फॉलिकुलर सेल्स और द नॉर्मल थायराइड फॉलिकल्स व्हाट यू आर हैविंग, दिस इज फॉर्मेशन ऑफ द जर्मिनल सेंटर्स, है ना. लिम्फ नोड में ऐसे ही दिखते हैं हमें जर्मिनल सेंटर्स. सो देयर इज इंटेंस लिम्फोसिटिक इन्फिल्ट्रेट, द डिस्ट्रक्शन ऑफ द ग्लैंड, दे आर बीइंग रिप्लेस्ड बाय द germinal center. So this is what is happening in autoimmune thyroiditis or Hashimoto thyroiditis. The gland is being infiltrated and it is getting destroyed, so that the hormone production is going to get decreased and TSH levels are going to get increased. So it is going, since it is an autoimmune condition, it is going to be associated associated with other autoimmune disorders like type 1 diabetes, SLE, Sjogren's, myasthenia gravis. This you need to remember. And sometimes there can be an increased risk of development of B cell marginal zone lymphoma. Okay, this you have to remember. So I have discussed one autoimmune condition which is going to decrease hormone levels. Another is Graves disease. Graves disease is also autoimmune. और इसमें हो क्या रहा है? There is formation of autoantibodies which have a stimulating thyroid stimulating immunoglobulin which has a function which is similar to TSH. ठीक है, so ये TSH का एनालॉग बन जाता है. So even if there is no receptor present to stimulate TSH, this TSI antibodies are going to mimic the action of TSH. So TSH levels are going to get increased, and there is going to be having hyperactivity of the thyroid gland. But important in Graves diseases, apart from thyroid specific features and other clinical features of hyperthyroidism, what else it is having? It is having extra thyroid manifestation also, like dermatopathies, and it can have ophthalmopathy. 20 to 40 years females में हो रहा है. Hashimoto was occurring as an earlier age late age group, 45 to 65 years. दोनों ही females में ज़्यादा common है. Now let us understand the pathogenesis. Clinical features दोनों में you will be able to write, I'm pretty sure. Here what is happening? There is increase iodization of the thyroid gland, diffuse thyroid gland hyperplasia, because the thyroid hormone TSH ka function is being mimicked by the thyroid stimulating immunoglobulin. So you have increased TSHR, you have goiter. So goiter related manifestation, thyroid related manifestation क्या हो सकती है? There could be increased blood flow to the thyroid gland. So that is why, since the thyroid gland is increasing, there is increase of the hormone production. The gland is there is increase of the sympathetic activity. There is sympathetic overactivity which is causing an increased blood flow to the gland, which is responsible for the audible brew which is there if you place a stethoscope over your enlarged thyroid gland. There's going to be diffuse hyperplasia, and that hyperplasia of the gland can be so large enough that you have it is compressing your larynx and you are having hoarseness of the voice and dysphagia. Apart from that, there could be what do you say, ophthalmopathy and dermatopathy. ठीक है, ophthalmopathy क्यों हो रही है? Because these materials, this immune response is also what it is causing? It is causing increased cytokine production, increased glycosaminoglycans production, which are causing what? They are causing more of the water retention. ठीक है, so वो extra orbital space में water को hold करके रखेगा, and that is why this infiltration of the retroorbital space is going to cause ophthalmopathy. Apart from that, there is lid lag. तो lid भी पीछे हो गई, eyes भी बाहर होगी. Why this lid lag is happening? It is happening because of sympathetic overactivity. So that is the reason for ophthalmopathy. And dermatopathy also you have प्री टिबियल मिक्सडीमा. टिबिया में ज़्यादा कॉमन होता है. यू विल हैव दिस डर्मेटोपैथी इन द शिन एरिया, अगेन बिकॉज ऑफ deposition of the glycosaminoglycans in there. Now what is happening in the gland? This is a red beefy, एकदम लाल, एकदम बीफ की तरह beefy appearance of the thyroid gland. There is diffuse enlargement, capsule is intact, but the gland, unless Hashimoto में it was pale yellow in color, the gland in here is red beefy in color because of the increased vascular supply which is there. And you will have the glands which are hyperactive, and scalloping is there. ठीक है, you have extensive colloid deposition which is in there in the gland, and like other like Hashimoto's, it is associated with other autoimmune condition like SLE, pernicious anemia, and type 1 diabetes mellitus. This I think you can write. Now goiter as such can come as a question also, but that is quite rare, but you do get a gross specimen of goiter. So important here is to understand the causes of goiter. Iodine deficient areas में sporadic goiter में क्या कौन से causes होते हैं, and why do you get this multinodularity? So this I was talking about the mahogany brown appearance of the thyroid gland, which I was saying. So this is a classical normal thyroid gland, but this is diffusely enlarged and you are having these nodules which are there. So extensive stimulation of the gland, it will lead to diffuse hyperplasia. Then there would be some glands which are in a state of involution, some glands which are in a state of hyperplasia. So this mixture is going to lead to multinodule formation, just like you have in cases of cirrhosis. So I am not going to explain this much because this does not come as a theory question for you. Thyroid carcinoma, very 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 important. PTC short note, PTC and follicular difference between medullary carcinoma, short note, very important for you to understand. Genetics पता होनी चाहिए, तो I will try कि मैं इसी में ही सारा सब कुछ तुम्हें बता दूँ. Differences between all the tumors of the thyroid gland as described are you will find in the attachment of the PDF notes. So here what is happening, you have PTC. PTC is conventional or you can have certain variants of PTC. अगर papillary thyroid carcinoma है, so there is going to be mutation in ret PTC. Ret PTC translocation, not ret mutation. Ret में mutation is happening in medullary carcinoma thyroid. लेकिन ret PTC translocation यानी कि एक जीन उठ के दूसरे पे जाके एक फ्यूजन जीन बना रहा है, that is happening in PTC. You have NTRK1, NTRK3 fusions. Then you have BRAF mutation. Can you tell me some other tumors which are having BRAF mutation? You are having hairy cell leukemia, melanoma, which is there. And you have papillary thyroid carcinoma where you have BRAF mutation. Now these two mutations we have spoken about in conventional PTC. Now what happens in follicular? Follicular में क्या हो रहा है? Follicular में you have most common RAS mutation. RAS mutation के बाद you can have mutation in P10 and you have mutation in PAX8 PPARG gene. Okay, so follicular neoplasm. जब we spoke about papillary thyroid carcinoma, it has certain variants which are newly being mentioned. So you can be asked in your vivas also, or you can have a MCQ in your theory paper that PTC has two variants of follicular. PTC has a follicular variant of thyroid carcinoma. अब उस follicular variant में you can have encapsulated variant which is called as non-invasive follicular thyroid neoplasm with PTC like features, or you can have an invasive variant of the follicular thyroid. So ये follicular variant के ही दो और variant है, एक encapsulated है और एक invasive है. इसको बोलते हैं invasive variant of PTC. ठीक है, invasive variant of PTC. बट इन दोनों में ही कौन सी म्यूटेशन कॉमन होंगी? दे आर PTC, ठीक है, बट दे आर कॉल्ड एज फॉलिक्यूलर बिकॉज ऑफ द फॉलिकुलर अरेंजमेंट. नॉर्मल PTC जैसा माइक्रोस्कोपी नहीं होगा. एंड ऑल्सो दे आर हैविंग RAS म्यूटेशन विच आर present in the follicular carcinoma. PTC में we had said that they have red PTC mutation, but they are RAS like PTC which are having RAS mutation common to the follicular carcinoma and follicular pattern common to the follicular carcinoma, but they are having but they are the variant of the papillary thyroid carcinoma only. Not detail you should be knowing, but you should be knowing that there are two variants like this. Now this is a gross specimen. If you have to describe, can you describe? There is some capsular invasion and there are some this papillary foci which are there in the tumor. So the tumor is very very ill defined, and although it seems to be well circumscribed, but there is no definitive boundary. It can be solitary, it can be follicular, and the cut surface है papillary foci. माइक्रोस्कोपी में क्या दिख रहा है? पैपिले बन रहे हैं ना. सो द कैरेक्टरिस्टिक फीचर इन papillary thyroid carcinoma, short note पूछते हैं. You have this papillary architecture, that these papillae are being formed with presence of a fibrovascular core. ठीक है, this core of the papillae is fibrous as well as it is having vessels, and these are the cells which are lining the papillae. So these cells are tall columnar cells having typical features. Typical features क्या है? Orphan NEI. Why orphan NEI? Because of this optical clearing which is there. ठीक है, आई जैसे लग रहा है ना, बिल्कुल एकदम chromatin is condensed at the periphery. Next feature, इंट्रान्यूक्लियस सूडो इंक्लूजन. न्यूक्लियस के अंदर है लेकिन सूडो इंक्लूजन है. सूडो मतलब नकली मुकली की इंक्लूजन है, बिकॉज इट इज एक्चुअली एन इनवेजिनेशन ऑफ द मेम्ब्रेन एंड नॉट अ ट्रू इंक्लूजन. And then you have nuclear grooves which are present. So these three features, nuclear features of the thyroid of the PTC, you have to say to call it as papillary thyroid carcinoma. बहुत सारे वेरिएंट्स हैं इसके. यू कैन रिमेंबर अ फ्यू: टॉल सेल डिफ्यूज क्लोजिंग फॉलिकुलर एंड पैपिलरी माइक्रोकार्सिनोमा. Okay, then grossly, I'm now so sorry, I'm going to start now. Next is a follicular carcinoma. Could you appreciate some difference in there? Look at this firmness, some yellow areas, some areas of necrosis and hemorrhage, and a little well circumscribed. So this is a gross appearance of the follicular carcinoma where the gland is asymmetrically enlarged, and इसमें the arrangement is that the tumor is, instead of the papillae, it is arranged in follicles. So you have variably sized follicles, कुछ बहुत छोटे हैं, कुछ बड़े हैं, कुछ बहुत बड़े हैं. And follicular adenoma और carcinoma को based on any nuclear feature या pattern से आप नहीं differentiate कर सकते हो. So whether it is a pre-invasive or an invasive condition, मतलब that whether it is an adenoma or a carcinoma, you can say only if there is capsular invasion or it is vascular invasion. ठीक है, या तो कैप्सूल इन्वेड होके मतलब ट्यूमर सेल शुड गो आउटसाइड द कैप्सूल, या द वेसल्स विच आर आउटसाइड द कैप्सूल दे नीड टू हैव ट्यूमर सेल्स. इसके अंदर वेसल के अंदर ट्यूमर सेल्स पड़े हुए हैं, दैट इज नॉट फॉलिकुलर कार्सिनोमा. बट कैप्सूल के बाहर एक वेसल में ट्यूमर सेल्स पड़े हुए हैं, that is capsular invasion, and that is follicular carcinoma. This is asked in the vivas, they can ask you. Next I'm going to talk about medullary thyroid carcinoma. ये दोनों PTC and follicular were happening from the follicular cells, but this is happening from where? This is happening for the parafollicular cells or the C cells which are there. And this medullary thyroid carcinoma is associated with the syndrome which is the Men's syndrome. So it can be sporadic also, it can be familial also. It happens from the parafollicular or the C cells and it releases a hormone known as calcitonin. Calcitonin का काम क्या होता है? कैल्शियम लेवल्स को कम करके रखना. इसके लिए हम स्पेसिफिक न्यूरोएंडोक्रीन मार्कर्स यूज करते हैं लाइक S100. You remember न्यूरॉन स्पेसिफिक एनुलेस, साइनेप्टोफाइसिन, क्रोमोग्रेनिन. ठीक है, इस टाइप से IHC और ये सब वी आर यूजिंग बिकॉज दे आर ट्यूमर्स ऑफ द C cells. So you should be knowing that there are sporadic cases, which most cases occur sporadically and in middle age group and they are unilateral. But when it happens in association with a syndrome, let's revise Men's syndrome also. It could be Men 2A, Men 2B. Men 2A में you have pheochromocytoma and parathyroid adenoma along with medullary thyroid carcinoma. In Men 2B you have multiple mucosal neuromas along with medullary thyroid carcinoma. And in familial cases, when they are associated with Men's syndrome, they are most likely to be bilateral and they occur in an earlier age group. As compared to sporadic cases, they will have C cell hyperplasia. And another important, I spoke that it is RET mutation at chromosome 10q. ठीक है, where you have RET translocation in PTC. Now look at the gross specimen. You can describe that it is firm, pale grey, tan, infiltrative. It is a little firm and it is not irregular just like PTC. ठीक है, it is well circumscribed tumor which is there. So grossly it's very difficult to differentiate कि follicular है या medullary. Only in the microscopy you can differentiate because microscopy इसकी बहुत ही characteristic होती है. You have polygonal or spindle shaped cells arranged in nest trabeculae or insular pattern. This is the insular pattern. Can you see that the tumor cells are arranged in nest where the tumor cells are here arranged in a palisading pattern separated by a fibromuscular stroma. So ये tumor के nest बने हुए हैं. ठीक है, बीच बीच में you can have this amyloid stroma, very characteristic. अच्छा, sorry, when I spoke about calcification, PTC is known for calcification and the calcification is present in a world form that is known as psammoma bodies. Apart from PTC, you can have psammoma bodies also in serous ovarian carcinoma. ठीक है, please do remember that. So you have this insular pattern, you have deposition of amyloid, very characteristic of medullary thyroid carcinoma. And you can have immunohistochemical method, just like I said, you can have synapto, chromo and S100 to highlight that it is a medullary carcinoma of the thyroid gland. Can you appreciate this pink material amyloid stroma in between the tumor cells which are arranged in trabeculae, है ना, or in diffuse infiltrating pattern or in some nest. So this has covered all the important topics of the thyroid gland. Please do read from your notes, your own notes, as well as some of the detailed notes which are attached here in the PDF.